Okay, so is your heart beating normally? Afternoon presenters, yours might not be. But on the whole, you guys probably think that your heart is beating normally. But how can you be sure? My name is Jaime Robb, and today I'll be presenting my research into improved methods for magnetic resonance imaging of the pulmonary vein region of the heart. So what is the heart? Essentially, it's a mechanical pump that functions to keep us alive. It consists of 4 chambers. So the top 2 here are the atrium, which are filled by the veins. When these contract, they push blood into the lower chambers, the ventricles. When these contract, they're stronger and they push blood up and out of the organ. The heart consists of 2 circuits, the first of which is the pulmonary circuit that I'm interested in. Through this, you can see that blood is pushed out of the heart and travels up to the lungs. The lungs are an air-dense tissue. Once they've picked up all this useful air and nutrients, blood returns to the left atrium through 4 pulmonary veins. But what actually controls the heart? What makes it do this beating action? So essentially, it's all controlled by an electrical circuit. And it all starts in the pacemaker region up here. An electrical stimulation passes through the muscle so that the organ contracts in an ordered fashion. It's in synchronicity with each other. And this produces a signal which we know as a kind of normal heartbeat. This is what we don't want to flatline ever. So it's normal and it's uniform. But what happens if the heart undergoes trauma or becomes injured? Well, then we're faced with problems because our heart no longer beats in synchronicity. There's a wrong connection or some incorrect wiring within the organ. It means that they don't beat in time with each other. So we end up with a signal that's not uniform, has a lot of variation, and we've got an irregular heartbeat. So in this case here, we're looking at atrial fibrillation, which is the most prevalent irregular heartbeat. It affects more than 20 million people worldwide. And a lot of people live their life unaware that they have this problem. It's undiagnosed, and it's only at the point where it's causing problems that it's then diagnosed. It can do things like increase your risk of heart disease, heart attack, quadruples your chance of stroke, and as you age, your heart, of course, it weakens and copes less under exercise and stress situations, and that can be enhanced if you have an irregular heartbeat. So how do we eventually diagnose this? So currently, what we do is we inject a chemical into patients, and that means that when we image the body using different imaging modalities such as MRI, we can see this anatomy better. But injecting chemicals into patients isn't always the best idea. It's not suitable for all illnesses, so we really need a better clinical option. So what is MRI when I'm talking about it? So our body is mainly water, okay, and we use the hydrogen within that H2O to image our internal organs. These molecules are constantly rotating within the body, but they're all at random orientations to each other. You can think of them as rowdy school kids in the playground. But when we put them into a magnetic field, they all become aligned and start to spin at the same rotational frequency, known as the Larmor frequency. So essentially the kids are shushed, they're facing their teacher, and they're all behaving the same way. So cumulatively, they have the effect of magnetization. There's no signal at this point and we can't tell anything. So what we have to do is apply another magnetic field. This is non-constant and delivered through radiofrequency pulses. Once magnetization is in the transverse plane, it then begins to rotate in a motion called precession, and we can acquire a signal. But this doesn't last long. M wants to get back to where it's comfortable, and it returns to this equilibrium state, firstly through T1 relaxation as energy is lost to the surroundings, and through T2 dephasing as the school kids get rowdy again. Consequently, M takes a spiral path back up to its equilibrium state. And during this time, we acquire a signal about tissue. This is repeated lots and lots of times during any given scan. So for anyone who's not had an MRI scan or isn't familiar with what they look like, most of them tend to look like this, where the patient will lie on the scanner and is placed into a magnetic field surrounded by lots of different hardware components. And what can we get out of an MRI scanner? So a lot of the time we're just getting a static image, a single image of anatomy, and lots of diagnostic information. But in the heart, we want to look at the whole heartbeat, so we create a short movie. The way we do this is we acquire images over several heartbeats so that we have sufficient data. And during this time, we ask patients to hold their breath. This is to reduce the motion of the chest wall as we breathe, and consequently there's no blurring during images. So feel free to start holding your breath now. The clinical threshold is about 20 to 25 seconds. But this is challenging for even a normal healthy person, let alone if you're elderly or severely ill. But consequently, we get really high quality images of different views of the cardiac anatomy, such as 4 chambers and the vessels that extend throughout the body. And breathe. So what's the problem? Okay, because they all looked fantastic. But when we look at the pulmonary veins, it's a different story. In a static image, you can see the left atrium, that top chamber, and 2 pulmonary veins, one from each side. Looks beautiful. But when we introduce cine imaging, then we're seeing, it's not working? Okay. This dark patches that are now replacing the pulmonary veins. Okay, so we can no longer see this anatomy, we can't make good diagnosis, and we certainly can't make any treatment plans for a patient. Why is this happening? That's the first thing to understand before we tackle the problem. So what we can do is we can look at how the MRI signal behaves at different hydrogen frequencies. So if they're spinning at different speeds, how does the signal that we acquire change? We see at very specific speeds, signal drops to 0. So this corresponds to the dark patches that we saw in those images. Why does this just happen in the pulmonary veins? Well, as blood is flowing up and round through the lungs, it then enters a completely different chemical environment. The lungs are filled with air and lots of gases, and this makes hydrogen really excited, so it begins to spin faster or slower. Then as it returns to the left atrium, it's in this excited state, and the MRI scanner isn't expecting that. So it can't detect signal from it because it's no longer behaving in the Larmor frequency as expected. So how do we overcome this? So one method is linear combination SSFP. So that secondary magnetic field that we were applying through pulses, we can apply at different angles to the patient. And as we do that, we change the way that the signal behaves under different hydrogen spin frequencies. So as you can see here, we're increasing the angle of application by 90 degrees each time. And consequently, the signal versus frequency relationship changes. It's the same shape, but each time it's shifted. This means that the nulling points are different under each case. So when we just simply add these together through basic addition, we can end up with this signal. As you can see, there's no nulling across all the same range of frequencies, and it's much, much more uniform. All seems well and good. So why has no one done this in cardiac scanning before? Well, to apply these 4 different cases, you increase your scan time 4-fold. This means increasing your breath hold to over a minute, which is just not possible even for Olympic swimmers. So to overcome this, we can radially undersample. This means that each measurement we acquire less data than would be desired, but it's still sufficient to get an image. With this, you increase streaking artefact. You see you get ugly images that look like this with big sun ray artifacts throughout them. So to try and combat this, you can interleave projections, such that within a single scan, you acquire 4 measurements. Each measurement has a different angle of application, and we acquire the data slightly differently each case, such that when we add the 4 together, it resembles a fully sampled data set. So I did a lot of simulation and phantom studies prior to trialing this in humans, but the human stuff's more exciting, so we'll just skip all that. The first step is to quantify the frequency of hydrogen within your anatomy of interest. So you can see here on this colour map, we're looking at the different frequencies of hydrogen within an imaging slice. The red arrow corresponds to the left atrium, and the white are the pulmonary veins. You'll see there a very clear difference in the colours, and that corresponds to a difference in frequency of about 70 to 80 hertz. And in patients where we saw more severe nulling and dark patches, this extended up to 145 hertz. So from that, we can imagine that there's spins in one part of the spectrum and some in a completely different area. So this is why we know that the spectrum is the reason for this dark patches. So with the current gold standard, we see that loss of anatomy that we've seen before. But with linear combination SSFP, that pulmonary vein reappears. We can clearly see it, and we could even draw around it if we wanted to. But we see that horrible artefact. By interleaving our data sets, we improve that slightly, and even within the anatomy of interest, it's a lot clearer. To look at a cine example here, you can almost see as the blood is entering the chamber that dark patches are introduced. So with LC-SSFP, the pulmonary veins are much, much clearer throughout the heartbeat. There is a little bit of flow non-uniformity there, that is something that the project is still trying to overcome to make sure that it's completely uniform throughout the heartbeat. So how do we quantify this, and it's not just you saying your image is better than my image? Well, we took 9 volunteers, imaged them with the current gold standard and with LC-SSFP, and they were graded on the following characteristics. And then statistical analysis was carried out to see if there was significant difference in these results. So we saw a significant improvement in pulmonary vein detectability, significant improvement in the number of pulmonary veins that could be seen. This improved by 61% across the dataset, all down to the fact that the off-resonance dark patch artefact was reduced. There was a significant increase in the streaking artefact due to undersampling, but this did not overall negatively impact image quality. So all in all, the factors that we wanted to improve had improved, all with not a significant negative impact. So to conclude, the problem that I was addressing was that the current MRI techniques are not suitable for diagnostic use in the pulmonary veins. A method such as linear combination steady-state free precession could reduce the effect of these dark banding and nulling regions, and the use of undersampling and interleave projections means that we can keep the breath hold scan time down to clinical threshold. Further problems are with that flow non-uniformity I mentioned, and the future potential and impact of this research would be replacement of contrast-enhanced techniques that rely on chemical agents being injected into patients, so we can offer more individualised patient care for atrial fibrillation patients and improve the long-term success of their treatments. So thank you very much for your attention, and I'd like to welcome any questions.
So I have 2 questions from the audience. The first one is, will this work on other bits of the body that move too, or is it just used for the heart?
Yeah, so the technique LC-SSFP has been demonstrated for static imaging. So for things like the legs, arms, we're not worried about breath hold scan time there because you don't have to hold your breath with it, it's not moving. So it works really well in static imaging, and that's one of the hopes, is that with the fact that we've implemented this with reduced scan time, it could be used in things like the digestive tract, looking at how, because your esophagus kind of moves over time, there could be implications for its use in that. Hopefully, that's where it'll head.
And the second audience question is, are there still some people that this won't help? For example, if they can't hold their breath for that long?
Yeah, so there's some things that you can do to kind of compensate for that. So when you're setting up a scan and the patient's in the scanner, there's some things you can reduce, usually with a trade-off in image quality. So you slightly give up a little bit of your resolution or a little bit of the kind of diagnostic value of it to shorten the length of the breath hold time there. There's other things like you can, track your patient's breathing in a similar way to the way we track their heartbeat. You just stick on some sticky pads and kind of monitor the way that they're breathing, and you can kind of trigger your acquisition to when they start their inhalation or when they're expiring. You can take a really, really long scan over lots and lots of breaths and kind of take the average over that time. There's a few different techniques within MRI to kind of compensate for people who they can't hold their breath there.
So I was wondering, this was done in healthy volunteers, and I was wondering if you moved to patients with atrial fibrillation, for example, where perhaps there might just be minor changes in the structure of the pulmonary veins. Do you think it would be accurate enough to diagnose?
Yeah. So, the hope is to use this in atrial fibrillation patients. Once it's fully optimized, it would probably go to clinical trials to check its viability with patients. But what they use this for, and what ultimately we'd like to do, is develop a 3D version of it. And for treatment of pulmonary vein, it sounds kind of grim, they put a little catheter in through your leg, up through your vasculature, into your heart, and effectively burn some of the heart tissue away. So we actually want to be able to see any irregularities in the anatomy, to be able to know what to burn and what not to burn. So even though there are structural difficulties or differences there, that's what we want to be able to identify there. And the differences in their heartbeat, that's something that the scanner is already set up to kind of compensate for.
Any other questions? Okay, thank you. Can you join me in thanking Jamie one more time?
Thank you.